Thank you for the introduction and for having me as part of this forum. And it's my great pleasure to speak to you this evening about updated female infertility evaluation and treatment of unexplained infertility, which there's quite a bit of good evidence to guide us on how to move forward. So without further ado, we'll get started here. And please let me know if you have any difficulties with sound, let me know. So I've set the objectives as for female infertility evaluation, really just to give some broad overview and context of, definitions, looking at the indications for testing, because really they've changed, describe the approach that we should take when evaluating infertility, and to look at overall ovulation dysfunction, how we evaluate uterine tubal pathology, and how we should approach ovarian reserve testing. In terms of the treatment of unexplained infertility, I'm going to review the evidence for management and contrast how the guidelines look at that, both in the UK, looking at the NICE guidelines, the American guidelines, and the Canadian, given where we may all work in different places. So infertility is considered a disease by a number of working groups, and it's really defined as a failure to achieve a successful pregnancy after 12 months of regular and protected intercourse. There is different definitions out there, but this would be the most common and mainstream used. In terms of, timelines to achieve a pregnancy, we see a lot of people get pregnant quickly within 6 to 8 months. But by 1 year, we know that 15% of couples will not have achieved a pregnancy, with that remaining 15% who are not successful. If you give them more time, usually in the second year, half of them will conceive. And so that's at the 2-year mark. Really, it's quite meaningful that they often have a low fecundity or a low likelihood of pregnancy in a given month. And we look at studies like this from Zinnemann et al. There's other studies that have looked at bigger populations, but they all show the same thing, which is the population as a whole is very heterogeneous in terms of our capabilities to reproduce or conceive. And usually within the first few months, we'll see the greatest odds of success for those who are super fertile. They fall out of the group, and by the end of a year, you will see those who are remaining as having inherently lower odds of pregnancy per month. And we quote less than 5% odds of pregnancy at a year. And really the crude numbers could be as low as 2% per month. When we look at age and how it affects our likelihood of pregnancy from the get-go at the very beginning of trying, the best probability obviously is for those under the age of 30 years. But if we look at the common group of people presenting to achieve a first pregnancy, where in Canada or North America, it's definitely over the age of 35, we're seeing couples starting out inherently with a lower odds right away. And so for someone starting pregnancy at the age of 40 years, they start with a 5 to 10% odds of pregnancy per month. And that needs to be considered when we come up with when should we see these patients to help guide them and give them better success with intervention if needed. And so this really is where we get our rationale for when we should evaluate patients. And it takes into that consideration of age. So if you're under 35 years of age, there shouldn't really be great harm with giving you longer to achieve a pregnancy on your own. And we look at that as being a year of trying. If you're over 35 to 39 years of age, we certainly want to see you within 6 months of trying. And if you're over 40, some would argue it's reasonable to have an immediate referral for evaluation, or at least within 3 months of trying. And part of that is just acknowledging it takes some time to get the evaluation completed. Now, there are some studies that have looked at those who are conceiving using donor sperm, whether that be a heterosexual couple who have severe male factor and require anonymous or known donor sperm, or is it a single woman or a same-sex couple who are looking at insemination? In these scenarios, we're really looking at evaluating after failed cycles of insemination earlier than what has been outlined before. And this is on the basis of just acknowledging that the fecundity, or the likelihood of pregnancy per month with donor inseminations, is actually lower compared to those who are using fresh sperm. And we quote a 20% chance of success with fresh sperm IUI in the first few months in a reasonable candidate or a younger patient. And you compare that to 9% per month when using frozen sperm. So the current guideline from the American Society of Reproductive Medicine is to consider evaluation sooner in patients using frozen sperm. Now, if someone right off the bat presents with risks for infertility, you may not want to guide them to have a full 12 months under the age of 35. And examples would be patients who have irregular cycles or infrequent menses. You're just wasting their time. These patients should be evaluated right away. Or someone with a background history of an STI or significant pain that makes you suspicious for a condition like a peritoneal disease like endometriosis, or if there's suspicion for male factor infertility, if there's overt sexual dysfunction that prohibits couples from getting together, or if there's a background history of genetic or acquired conditions that may be associated with diminished ovarian reserve. So someone who's previously had chemotherapy. So these patients would be seen right away. And certainly in our world, we're seeing, people building their families in different ways. And certainly the LGBT community is pretty prominent here in British Columbia. And so we have to tailor our evaluation. If there's 2 women, 2 men, perhaps they're looking for a surrogate, maybe it's a single woman. And so that may not be as common elsewhere, but certainly is in my world every day. And there are other scenarios where we're seeing couples that aren't really, by definition, affected by infertility, but they may be wanting to use assisted reproductive technologies up front. And certainly they would require an evaluation, and that would include single women wanting to conceive on their own, or someone who's completed multiple failed attempts at pregnancy and had first trimester miscarriages and has recurrent pregnancy loss, or those where they have known heritable conditions and are genetic carriers perhaps, or where they want to do pre-implantation genetic testing for aneuploidy, monogenic diseases, or structural rearrangements. And so the evaluation overall should aim to detect the most common causes for infertility. And the approach that we take should be systematic, expeditious, cost-effective, and be least invasive. And consider the patients in front of you. You may need to tailor that approach. So an example would be a woman who is part of a couple, and they've never had well-timed intercourse because her cycles are completely irregular, or she has amenorrhea. It would not be unreasonable to fix her cycles first and give them attempts at pregnancy with corrected ovulatory cycles, and avoid doing an invasive test like a hysterosalpingogram, for example. And we'll go through these step by step as we go through. Starting out as part of an evaluation, we always use a history, an exam, and investigations to guide us. And this is just to give you a template, or to remind us all of the parts that are important in a history, but certainly a reproductive history, a full gynecologic history. And so from menarche through to information about menstrual cycles, cyclicity, intermenstrual bleeding, postcoital bleeding, pap smears. If they've previously had procedures on the cervix, that may lead you to think of stenosis, for example. You want to know about past use of contraception. Perhaps they've had some side effects related to perhaps an IUD or endometritis as a consequence. We need to know about coital frequency and timing of intercourse. And if there's any kind of sexual dysfunction, we want to know about pain with menses, chronic pelvic pain. And these things will help, again, guide you in terms of where you will go with your evaluation. Certainly, anyone with PID raises your alert or alarm bells for consideration to tubes being affected, so tubal pathology. And then a general endocrine evaluation with thyroid questioning, questioning around hyperprolactinemia, so headaches, galactorrhea, changes in their cycles with respect to that, or hirsutism associated with irregular cycles, looking for things like polycystic ovarian syndrome. Medications can affect how women's cycles proceed, so we need to know about those, and if they're on a prenatal vitamin, any allergies to medications. And the family history is really important. Certainly we have a large population of Asian descent, Mediterranean descent here in BC, and so we screen all of our patients for thalassemia screening upon meeting them initially. And we do see a lot of Ashkenazi Jewish descent couples, and again, they can be offered carrier screening given the autosomal recessive conditions that can be found in that group. And then we want to look for, because in here in BC as well now, marijuana has become legalized and certainly can affect fertility. So we will often ask about recreational drugs. And in the physical examination, we are looking at general BMI can affect cycles being ovulatory. We want to look at their blood pressure, pulse, weight. And again, you can tell a lot by looking at someone, do they have acanthosis as a sign of hyperinsulinemia with PCOS? And again, looking at a targeted exam of the thyroid, the breast, any signs of androgen excess, and then a pelvic examination where you're able to look at the cervix and ensure it appears normal, that it doesn't look scarred. You may do a manual examination, get an idea, does the uterus feel normal? Does it feel bulky? May there be pathology there like fibroids? And again, looking for signs of pain or discomfort that may suggest ovarian abnormality or endometriosis affecting the pelvis in general. And when we look at causes of infertility, we can break it down as between couples or just the woman herself. But obviously, when we're looking at couples, a third of the time, there'll be a male factor associated with infertility. And for women themselves, ovulatory dysfunction is pretty common. I would say in my world, unexplained infertility is overrepresented at more than 30% than ovulatory dysfunction, perhaps more like a 10 to 15%. But this obviously varies depending on what your population is. And in terms of evaluation for a couple, you would look at male factor as well. And the guidelines do suggest that as soon as you start or instigate an evaluation for the woman, you should be looking at doing that for the man also. And I'm going to start by targeting our evaluation discussion right now to the ovarian factors. So we're going to talk about how you evaluate ovulation, ovarian reserve, and then we'll move on to tubal and uterine issues. So ovulatory dysfunction represents up to 15% of couples. It can be overtly very obvious where a woman has amenorrhea, or perhaps she has a very difficult gynecologic history to interpret, and that usually is a sign of oligomenorrhea. They can't really detect when their last menstrual period was. They have significant menometorrhagia or intermenstrual bleeding. And the first thing we need to do in these patients is really exclude pregnancy before we go on to our next steps. That's a pretty common exam question. What's one test you would perform for someone who presents with ovulatory dysfunction? Do a beta HCG. And then you can't take it and just leave that there. You need to make a diagnosis, because a lot of the conditions that affect or lead to ovulatory dysfunction certainly have associated health implications. And in some, we do still see after a thorough evaluation, they can have quite an obscure underlying cause, and it may not be so clear, and it could be just something that's quite subtle, but the diagnosis should be strived for with a full evaluation. And I've just put here for you the WHO classification for ovulatory disorders. Group 1 being those things that affect the hypothalamus and the pituitary, and patients often have what we call hypo, so hypogonadotropic hypogonadism. And this would represent those patients who exercise significantly or diet or have significant stress in their lives. And maybe some genetic components like Tallon's disease would affect this for sure. And then group 2, where you're looking at other hypothalamic pituitary ovarian dysfunction, but this really alludes to PCOS. falling into this group and would represent 80% of all the patients. And group 3 are those that have ovarian failure. So they're hypergonadotropic, hypogonadism based on their testing. And so when we move through all of this, a menstrual history will guide you significantly as to whether or not there is an ovulatory issue. And we look at looking for normal cycles between 21 and 35 days. They should be predictable and consistent. And I ask patients for meliminal symptoms, so progesterone-like symptoms that really do signal to the fact that they're having ovulatory cycles. And in patients who describe consistent menses, the likelihood of them having a true ovulatory cycle is very high. It's 99.5%. So you can be reassured that if you are taking a consistent history, they're ovulatory. There is some normal variation amongst women who are still ovulatory. And this has been followed in groups of women over a year, where 70% will have some variations, but those variations are considered normal up to 5 days. Now, ASHRA has put out a definition of what is considered irregular for menstrual cycles. This was part of their PCOS guideline. It's very helpful, and it just recognizes that after menarche in that first year, the pubertal transition, we expect that menstrual cycles will be irregular, and we shouldn't really be making diagnoses of ovulatory dysfunction in that time. That's part of the normal pubertal transition. But for the first 3 years after menarche, you may actually have slightly longer cycles while the HPO axis is maturing. And so if you have cycles that are less than 21 days, that is considered abnormal, or greater than 45 days, also considered irregular in those 3 years. If you get beyond the 3 years from menarche, cycles should be within 21 to 35 days. They should have settled into a more ovulatory pattern occurring within 35 days. And anybody who has less than 8 cycles a year has irregular menses. And again, in that 1 year after menarche, anyone at all who shows up and says, I have not had a cycle for 90 days, so about 3 months, that is considered an extreme and suggests irregularity. And primary amenorrhea is where you don't have any menses by the age of 15, or 3 years after the phalange of breast development. So this is useful to help guide you from a history. And certainly where that patient gives a difficult history to interpret, where they're unsure of what is going on and when was their last cycle and how many they've had in a year, history alone is really sufficient to make the diagnosis of oligomenorrhea or amenorrhea. You don't need to go to the next step of laboratory testing with progesterones to confirm that. But you do need to establish an underlying diagnosis. So you do need to go to the extent of trying to work out why. And so part of that will include hormonal testing. And you'll see here I've put in the patterns we see for FSH and estradiol given the different WHO classifications, and can also help guide you as to what the appropriate treatment for those patients should be. So routinely, FSH and estradiol and a TSH is performed. Prolactin is no longer considered upfront definitively needed for testing, only if the patient presents with ovulatory dysfunction or galactorrhea. So in this patient group, you would add a prolactin in. And for those who present and you think they have FSH and estradiols in the normal range, and you maybe are considering a diagnosis of PCOS, you would need to do a full workup for that. And I have not gone into that today. I think that's a worthwhile, probably individual talk on its own. Now, in terms of adjunctive testing and objective testing you can do, the gold standard for establishing whether or not someone is ovulatory is actually a serum progesterone. And we know that based upon when someone ovulates, that testing needs to be adjusted. And for the most part, we would draw progesterone 1 week back from when the menses was due. So if they have a 35-day cycle, you would want to do that testing on about cycle day 28, much later on, to establish if it was an ovulatory cycle. And someone with a 28-day cycle, you're going to do that testing on the standard, what we say, cycle day 21 progesterone. And there is no qualitative information that we take from progesterone values. We're just looking for a threshold value that says, yes, we're certain based upon this value that the patient has ovulated. And most places would use 3 nanograms per mil or greater, or here in BC, we use like 10 nanomoles per liter. Anything above that is, you can be pretty certain that patient ovulated. And you'll often get questions from patients around luteal phase deficiency. Do I have an issue with my progesterone? Am I deficient? And I tell patients that we cannot draw that information from doing this test. It can elevate progesterone from the point of ovulation 7-fold over hours. And we just don't know when to measure for its peak. And we certainly wouldn't expect that you need to do repetitive progesterone values. It doesn't really bring you any further information. Easy testing that patients can do at home to help guide them for timing of intercourse around the fertile window. We know the most fertile days are the 5 days leading up to the day of ovulation, with day 0 here being the day of ovulation. And we can use at-home LH kits. And these ovulation prediction kits, you want to have a good brand that you can rely upon. We use 2 different brands here commonly in our clinic, and when used properly, they're very reliable. They're most reliable when their urine that you're testing is from a midday sample or late afternoon or evening. It's less likely to be reliable when you're using the first morning void, because all of that hormone overnight that's being released is being stored in the urine from the night before and can give you an early false positive. Regardless, we know that sperm lives for 3 to 5 days from intercourse and should still cover your window of time, knowing that the peak from an LH surge will dictate the likelihood of ovulation within 12 or 24 to 48 hours. And so this can really help patients at home and who certainly are using ovulation induction attempts to time intercourse. Basal body temperature charting is something that often patients will come to me with, having been guided to use by maybe a family doctor or a naturopath more commonly. I think they're very tedious. They often misleading. I think patients have a hard time and get very frustrated using basal body temperature charts. You need a really, really good thermometer that is accurate, because you're looking for a thermogenic shift that happens with release of progesterone, and that difference is a 0.4 to 0.8 degree Fahrenheit shift. And you see here in this graph, the purple line, which shows you that the temperature is increasing and peaks just with the serum progesterone at its highest level. But again, you need a very accurate thermometer, and this is not being recommended by ASRM as a reasonable or first line option for people to use. Now, ultrasound can be really helpful, but it depends on the timing with which you're using ultrasound to establish ovulation. There's a lot of other things you can get from 2D imaging using transvaginal ultrasound. The left image at the upper left is just looking at a sagittal image of the uterus. What you can see here is that there's a thick triple line pattern here of the endometrium. And that says that there's certainly activity from estrogen, and makes you think that has to be coming from somewhere, and likely a dominant follicle or follicles. And when you go to look at the ovaries below, you see a large dominant follicle. And it's nice to see alignment of what's happening between the ovary and the uterus. But also you get the opportunity to look for pathology on the ovaries. You get to look at adnexa, get to look at the shape of the uterus, morphology, the myometrium. Are there signs of adenomyosis, fibroids, polyps? You get a lot of information from 2D ultrasound. And if we shift to the right-hand side, if you're doing this in the luteal phase, you will see changes from progesterone where you see a more homogeneous lining throughout. And again, you may be able to document a corpus luteum with color flow around the remnant follicle. And they often can look hemorrhagic or that ground glass appearance that could be mistaken for an endometrioma if you didn't consider this as a corpus luteum. So this can be helpful. Endometrial biopsy was something that was done in the past. It's not recommended to do this any longer. We're not looking for the secretory endometrium in this manner. We know that it's not reliable. And Choosing Wisely, which is a group here that really sets out guidelines as to what is reasonable and not reasonable to do as part of an evaluation, has clearly stated that this should not be done any longer. So I'm going to move on to ovarian reserve testing. And when we talk about ovarian reserve, we're really referring to the number of oocytes remaining in a woman's ovaries, knowing that we have our greatest complement of eggs during our gestation at 20 weeks. And at the time of birth, we've lost a lot of our eggs and are down to 1 to 2 million. And in puberty, we've lost even more, and we're at about 400 to 500,000. And at menopause, some remnant follicles left within the, you can see the histological slide here on the right that really shows you what a slice of an ovary looks like when we're menopausal. There's still follicles there, they're just poor quality and they're not responding. And so it is a quantitative assessment when we say we do our ovarian reserve test. Quantity is very different from quality. And this is one of the most important things to keep in mind when we're doing this kind of an evaluation for a woman. Quality relates to the capability of an egg to fertilize and to result in a live birth. You could have a very poor quantity of eggs, a very low number, but at any point in time, you could throw out that right good quality egg that leads to a live birth. And this is where the deficiency lies really in ovarian reserve testing, in that we cannot dictate whether there really is a good quality egg, when it will come, but certainly there's value to establishing quantity for counseling, and we'll go through this. So when we talk about egg number, we do use it to try and define one's reproductive potential. And when we say there's diminished ovarian reserve, we're really meaning that someone has gone to a treatment where they've done ovarian stimulation, they've taken some kind of either medication, whether that's an oral agent or injectable gonadotropin, to stimulate eggs to grow. And they've had a reduced outcome, a poor outcome, a low number of eggs retrieved compared to those at their cohort at their age. And we know overall our ovarian reserve is inversely proportional to our age, meaning the older we get, the lower it is. And it can vary significantly for any given age group. And this is important. So we know that 10% of all women will demonstrate a lower reproductive potential, have a lower number of eggs than their peers for a given age. And 1% will have premature ovarian insufficiency. And we're trying to identify those women that are at risk of that reduced reproductive potential, and perhaps give them the opportunity for guiding them to be more aggressive in their attempts at having a pregnancy sooner. And this is where I use this more and more now for women who are looking at trying to establish what they should do in their reproductive lives. But I wanted to give you where there's indications for ovarian reserve testing, and certainly for all patients who are about to embark upon infertility treatment. It's a routine part of the evaluation. And for those, again, who don't have infertility but are looking for an individualized assessment, so we can give them their best protocol, because we, again, are going to choose the kind of treatment that's best for them, and it helps us with their dosing. In those who have premature ovarian failure, insufficiency, or a family history of early menopause, this can help them early in life to set the stage for perhaps how they want to plan their reproductive life. For women with polycystic ovarian syndrome, not that AMH is considered a surrogate for making a diagnosis, but it's certainly very common to see women with PCOS having a very high egg reserve, and that falls into the Rotterdam criteria now to make a diagnosis of PCOS as those who have a large number of follicles in the ovaries. Now, women who are considering elective or social egg freezing, which has become really prominent over this past year here in Canada with COVID. We're seeing a huge number of women wanting to do this. They're looking strongly to ovarian reserve testing to prognosticate their outcome, just give them a reasonable sense of expectations. For those who are doing egg donor, we'll do this to establish their candidacy to be a donor. And for anybody who's going to embark upon chemotherapy, if they have the opportunity or time to do evaluations before and after chemotherapy, that can give them a sense as to what their remaining egg reserve is. Certainly, and I'm going to allude to this when we talk about unexplained infertility, I am going to go through endometriosis and ovarian surgery and how we can use assessments of ovarian reserve preoperatively. We can use AMH in those who have granulosa cell tumors to look for a diagnosis and to evaluate or survey for recurrence. And those who have perimenopause and are going through significant changes, which may be quite subtle to start with, ovarian reserve testing can help kind of pin down where they are in their reproductive lives. And again, women with BCRA1 or FMR1 mutations, very helpful too. Now, our common assessments for ovarian reserve are doing FSH in the early follicular phase, day 2 to 4, with an anchoring estradiol. We also look at an antral follicle count and an AMH anti-Müllerian hormone level to help with us. I'm just going to check the chat. I'm going to address questions at the end. I just wanted to make sure you could still hear me here. Okay, so I'm going to keep going for now. In terms of antral follicle count, I tell patients it looks like a chocolate chip cookie. We're looking at these black little sacs within the ovaries, and we're counting them. And these again are follicles that are 2 to 9 millimeters in size. We're not really sure if they're coming or going in the cycle, but they give a very good estimate to the maximum number of eggs that you would expect to retrieve from something like IVF. FSH, again, there's caution with FSH. I quote this study a lot. This comes from Richard Scott from 2008. It's not a small study. It had 8,000 women in the study, and they looked at FSH values to dictate the likelihood of delivery. And what they show here is when the FSH is 18 or above, really no one brought home a baby. They may have had pregnancies, but they certainly didn't have deliveries. And again, this would be modified by age. I reiterate to patients often, I would rather take quality and be a much younger woman over quantity and be older with a huge number. Certainly being younger, even with a low number, is much more desirable when you're looking at the balance of quantity and quality. When you see FSH values, though, here in this graph of 15, that sounds significantly high, and there'll be many IVF centers that will refuse patients access to IVF with values like that. And I have many, many patients who achieve pregnancy and ongoing pregnancy with FSH values of 15. But of course, the value with a test like this is really giving them counseling and ensuring that they are aware of what they're getting into in terms of a lower yield, a lower expectation from one single given IVF cycle. AMH is an amazing test in that it is much more accurate than an AFC and FSH for dictating egg reserve. It has a greater area under the curve when you're looking at its ability to dictate outcome. But again, outcome is quantitative outcome from a cycle of treatment. We're talking about the number of eggs growing or retrieved. We're not talking about live birth. None of these tests can dictate the likelihood of achieving a natural pregnancy or outcome of a live birth, because really, again, even with a low number, you can throw out that one great quality egg at any time that leads to the best ongoing live birth. But this is meaningful for women when you look at age, and I use this table every day in my practice because patients do AMH here very commonly. And we look at the average value for a given age, say a 30-year-old with a value of 2.4, and this is nanograms per mil. If you were going to convert over to picomoles per liter, you'd multiply by 7.14, or to go from picomoles to liter to nanograms per mil, you would multiply by 0.14. And in this, you see the 30-year-old has an average value of 2.4, but could be higher based upon how you choose to cut off those stats. But if I see someone who comes in who's 30 and has a value of 0.4 nanograms per mil, which is the average quantity of eggs that a woman has at 43, that certainly is meaningful for her if she's not planning to achieve a pregnancy anytime soon. Does not mean she's not fertile. she could still be fertile. It doesn't say that. It just means quantitatively she has a lower number of eggs. Now, this just says age and follicle number. We're looking at this graph that I'm sure all of you have seen many times over, which just again shows the number of follicles peaks at birth and declines steadily over our reproductive lives. And again, the number of abnormal oocytes increases, and significantly so over the age of 35 or to 38, and dramatically over the age of 40. And this is meaningful, and women even today still don't really get this. They feel that if they have a good number of eggs, even if they're 40, they're often very reassured by that. And I think the messaging has to be the single most important predictor of likelihood of pregnancy per month is age. So if you're older, you're still older. Doesn't matter if you have a big number of eggs. It just means you're a better candidate for outcome at IVF in terms of number of eggs. Now, when you look at ovarian reserve tests, you certainly want to interpret in the context of the big clinical picture. And so we use age and diagnosis primarily to dictate our counseling. We use ovarian reserve tests to augment that counseling further and to set realistic expectations, but it also allows us to tailor our treatment. And there've been many studies, and I've just quoted 2 here for you so you can reference them. Poor testing does not imply that you cannot conceive naturally, and you need to be careful with your counseling on that. And these studies are big studies looking at women, and EAGER is looking at aspirin use in women over their gestation. And they covered a huge number of women between the age of 80 to 40 years of age, and looked at women whose AMH values were low, and they certainly did not have infertility at a greater rate. And so, you know, AMH is not a biomarker of ovarian function. It is just a marker of quantity of eggs. Okay, so we're going to move on. Again, it's most useful in dictating oocyte yield. And again, I use this in patients who have really big egg reserves and who are infertile and are looking at IVF as treatment as a way to modify my dosing and to limit the risks of ovarian hyperstimulation syndrome. Now, extremely low values should not prohibit people from treatment, and we certainly do not. So I'm going to move on now to uterine issues, which when we have uterine pathology can certainly affect the ability of an embryo to stick within the window of implantation. And we want to know that the uterus is capable of supporting growth and development of an ongoing pregnancy. If we look at all women presenting with infertility, 16% will have a uterine issue. And they break down as more commonly polyps, so these benign, fleshy-like growths of the endometrium. 2.8% of women presenting will have fibroids, whether they're pushing into the cavity within the wall or serosal on the outside. We don't tend to think serosal fibroids impact fertility so dramatically, just if they affected the contour or the inner lining of the uterus, they're more meaningful. And a very low proportion of patients showing up firsthand will have adhesions or synechia affecting pregnancy. Now, if that patient gives a history of abnormal uterine bleeding, you're much more likely to actually find some uterine pathology. And you have many options on how you're going to evaluate that. And so I have here an image of a 2D image of a uterus, again, sagittal. You can see the endometrial stripe there, and in the middle is what looks like a polyp. It's well circumscribed by that triple line pattern, and you can see it quite clearly. If it was luteal, you'd have a hard time identifying that polyp within the cavity. And a test that's done quite commonly is a saline infusion sonogram, where we pass a little catheter into the uterus, inject some fluid so it acts like an anechoic contrast within the cavity. And then we look with ultrasound, and we get images that show us going from the top down here on the right. A uterus looks like there's maybe a posterior fundal fibroid. You inject some fluid and you see the black contrast from the fluid, and it really outlines nicely that fibroid as it abuts into the cavity. And this is something I would advise a patient to remove because it clearly interferes with the inner contour of the lining of the uterus. And the same goes for the bottom image, where you see it outlines the polyp quite nicely. So you get a lot of information from 2D imaging. Sometimes that's enough, but sometimes you need something with contrast to give you a better view of the pathology within the uterus itself. And hysteroscopy, so a camera test looking inside the uterus, would be the gold standard, certainly considered the best in terms of identifying pathology within the endometrium. But saline infusion sonogram is pretty close. 3D saline infusion sonography is excellent for identifying uterine abnormalities or uterine morphology issues. So if you're trying to distinguish between an arcuate uterus and a small septum, or a septum itself, or a septum and a bicornuate uterus, 3D saline infusion sonography may help. It's just hard to get a 3D scan often. Obviously, MRI would be useful for morphology in this setting, as part of this discussion. But transvaginal ultrasound is pretty good with a 91% sensitivity, but it really depends on the operator and where that patient is in the cycle. And then hysterosalpingography, so HSG, which we use to assess tubes, also gives us information about the uterine cavity. And so this is just more for reference. And we often will tailor our choice. So an HSG is pretty invasive, as is hysteroscopy. We do have the capability of doing office hysteroscopy in our clinics, and it's covered by MSP for them, so it's covered by the provincial healthcare system, so they don't have to pay for it. And HSGs are hard to get because they're done at outside X-ray clinics. And certainly MRI and 3D ultrasound, there are long wait lists in our world for those, again, because they're done at hospitals or radiology clinics. And just in terms of like a tubal assessment, HSG would be the easiest thing to do without putting someone to sleep and doing a laparoscopy and a chromatubation. And this is pretty good for identifying both proximal and distal tubal disease, but actually may require tubal cannulation if you get proximal spasm. And it looks like this proximal obstruction, and that's pretty common. So if an HSG yields a result of blocked tubes proximally, you have to think, okay, this may actually be a false positive. And 60% of the time, if you take those patients to laparoscopy, they'll be patent. But you can do saline infusion sonograms to establish tubal patency, but usually can't tell you which side is blocked. It will just show you there's fluid in the posterior cul-de-sac, there is a tube open. But HICOSY, or hysterosalpingo contrast sonography, when done well, will actually be able to establish the side that is blocked if it's truthfully blocked. Now, tests that are not routinely ordered anymore: laparoscopy for unexplained infertility, advanced sperm testing like DNA fragmentation tests, postcoital testing, thrombophilia, immunologic testing, karyotypes, endometrial biopsy, prolactin for everyone not needed, just ovulatory dysfunction, and luteal phase progesterones don't need to be done in those who give a history of being very regular. So I'm going to move on to the management of unexplained infertility, which is a little heavier because it's a lot of studies to guide us in this. But I've been, in my slides, I wanted you to have the references so you could go back and look at these. But essentially, laparoscopy for unexplained infertility, 2 landmark studies, the Endocan Study and the Gruppo Italiano Study. Endocan Study took patients who presented with unexplained infertility and looked for endometriosis. If they found endometriosis and treated it, those patients appeared to have benefit over time afterwards, compared to those who did not have endometriosis found and just had a laparoscopy performed. And the cumulative pregnancy rates were 31 in the treated group and 18% in those who weren't. And if you compared the monthly fecundity, it was not dramatically different, really, at 4% in those who had endo treated and those who did not. In the Gruppo Italiano study, they took patients with already predefined minimally mild disease on laparoscopy and then went on to randomize whether they would have surgery or not. So they had a comparison group with the disease that didn't have laparoscopy, and what they showed was the live birth rates were the same in both groups. There are some questions around perhaps biases and how they were treated post-op, but ultimately it leaves you with this. But the number needed to treat is about 12 if there was endometriosis found. But we know that not all patients with unexplained infertility have endometriosis. So if you have a patient in front of you that does not give a compelling history that makes you think, oh, they have significant pain, like severely painful periods, dysmenorrhea, dyspareunia, dyschezia, if they have none of those symptoms, it's very unlikely that you're going to find endometriosis. Conversely, though, if they give a significant pain history, you have a higher chance, an 80% likelihood of finding endometriosis on laparoscopy, and they're going to be the person that potentially sees benefit from being having their endometriosis ablated or excised. But for all comers with endometriosis, the number needed to treat is 40, so it's not great. And you can't ignore the fact that still laparoscopy carries significant minor and major risks of 8 to 9%. So to keep that in mind. And the other part is the impact that any kind of surgery on ovarian endometriomas, the impact that can have on one's egg reserve. So we know that just the presence of an endometrioma will actually be destructive to a woman's egg reserve. And looking here, you'll see on the left that if you compare all-comer cysts to endometriosis cysts, AMH in general tends to be a bit lower than for, say, a dermoid or a simple cyst. And then post-operatively, every patient will have a decline in their egg reserve after cystectomy, and it should recover over the next 3 months. But if you look at the degree of recovery, it tends to be better in patients who don't have endometriosis. And so, certainly if someone has bilateral disease, their AMH is even going to be further compounded as a lower value. So you need to keep that in mind, especially when they may be looking at moving on to something like in vitro fertilization. And AMH would dictate the likelihood of ovarian reserve or yield from that treatment. So I just thought it would be useful to keep the context of everything here. If you do an assessment of egg reserve for someone with endometriosis, and if it is impaired, the approach usually is to go ahead with some kind of IVF egg or embryo freezing before they would embark upon surgery. And the Canadian Fertility and Andrology Society and both ASRM as well as a laparoscopy is not warranted upfront in unexplained infertility in the absence of presumed tubal or pelvic pathology. What about expectant management? So a lot of our patients with unexplained infertility will be young and have good egg reserves, and you can consider them, reasonable prognosis for expectant management. Well, Sturs et al. Looked at about 250 people in a multi-center trial. These were young, under 35. And it's nice to know that you can quote like a live birth rate of almost 30%, 27% in 6 months. So that's good to know. But when you go on through looking at the other studies that look at expectant management, some patients find it completely unreasonable as an option. They're just not willing to go beyond their 2-year mark. They want to be more proactive. Perhaps they want a bigger family, more children, and that's totally reasonable. So I'm going to go through the evidence that's there for oral agents, so both clomiphene and letrozole or aromatase inhibitors, and intrauterine insemination, and them alone and together. And I just thought as a reminder, Clomid is a selective estrogen receptor modulator, binds to estrogen receptors, intranuclear estrogen receptors in both the hypothalamus and the pituitary, and abuts any kind of response given its competitive binding. And what you see then is no GnRH output and an increased GnRH output to try and stimulate some kind of estrogen production from follicles via FSH, because the brain is not able to see any estrogen circulating in the body. And as a consequence, you get folliculogenesis. But we also know it has effects on both the endometrium, cervix, and vagina, and cervical mucus. Letrozole, commonly used aromatase inhibitors. I know others can use things like tamoxifen I've seen used, but letrozole more so in the studies is blocking at the level of the 2-cell gonadotropin cell theory, right? It's blocking aromatase production from androgens. And again, there's no negative feedback to the pituitary gland. And because of that loss, you start to see an increase in the output of FSH and a greater drive for folliculogenesis. Now, when you look at the studies, and I hear this from patients, I just want to take pills, or I don't want to take pills, I just want to do insemination as a next step for unexplained infertility. I often will go through the study. I'm like, it's not going to help you to do any of these alone. Just do expectant management if you're not ready to move on to doing something that's actually going to increase your likelihood of fecundity. So in this study, and this is a landmark study, it's quoted everywhere, they looked at patients who really had unexplained infertility, like 30 months, they were young, and they randomized patients to either Clomid 50 milligrams, so you could argue that perhaps not aggressive superovulation to increase the number of eggs being generated. And really, we know that unexplained infertility patients, what's the use of monofollicular responses in these patients? You really need to superovulate them, and we need to have a fast droplative moving sperm inside the uterus at the right time. We're doing appropriate timing with insemination. versus just expectant management in this study. And insemination took place within 30 hours of the surge, and they did up to about 2 to 5 cycles in each arm. And what they showed was really, when you compared Clomid with expectant management, there was a decrease in overall pregnancies, and the same when you looked at IUI compared with expectant management, was slightly increased, but not statistically significantly so. And when you looked at age parity and duration of infertility, it gave the same results. And they actually quote like a number needed to harm with Clomid use alone for patients with unexplained infertility is about 33. So every patient who does Clomid, for 33 of them, one will have a lower successful pregnancy because of taking clomiphene. And for IUI, the number needed to be of benefit is about 17. So not an efficient treatment. And when you looked at significant times to pregnancy, there were no differences to expectant management. So, it's left with, well, do we offer patients expectant management? Well, it was a very positive patient experience in one study, the Storrs et al. Patients found it totally reasonable to wait another 6 months after the 2 years. Whereas in the Bedaiwy study from the UK, it was considered totally unacceptable. And it's also being shown by the same group to not be cost effective. But the Canadian response to this in our guideline is it could be offered if you're good prognosis, like you have a good egg reserve and you're young, and it doesn't put your definitive treatment to any detriment by waiting further. Now, IUI in a natural cycle is not recommended based on this study and others as well. Again, because it's a similar outcome to expectant management, and the ASRM agrees with that, as does CFAS, doesn't offer any benefit over expectant management. So what about ovarian stimulation with oral meds alone? Okay, and again, that would be what was looked at in the Bedaiwy study, but in a Cochrane database study with Hughes et al., they looked at Clomid. What they showed from 7 trials was that the live birth rate was lower and not statistically significant in the confidence interval distribution, but not successful in achieving a higher odds of pregnancy alone. And then in systematic reviews, same thing when they're looking at comparisons of letrozole to Clomid on their own in unexplained infertility. You look like pretty reasonable pregnancy rates when you look at these numbers here. Again, letrozole versus Clomid, no difference in outcome because it's not statistically significant based on those confidence intervals. And so the summary from that is Clomid does not offer benefit over expectant management, should not be offered on its own. And aromatase inhibitors should not be offered alone for unexplained infertility. And there's no benefit over Clomid alone. So what do we offer them? Well, my practice is to offer good prognosis patients oral agents with insemination based on a number of studies. Deaton et al. Was a really small study looking at patients with endo and quoted a better odds of success with Clomid IUI after treatment versus expectant management. There's another study showing you the same thing below here, and I'm just going to go on. Dr. Bedaiwy, who's moderating today, was part of the RCT in 2009, looked at 412 couples, young, like 29 years of age, with over a year of unexplained infertility. And when you looked at doing oral agents with IUI, the pregnancy cycles were 19% and 18% for letrozole and Clomid respectively, and cumulative pregnancy rates were the same. And in the biggest trial looking at this, which is the Amigos trial of 900, again, good prognosis patients, but in this, they had a third arm. They compared gonadotropin superovulation IUI with letrozole IUI for superovulation and Clomid IUI over 4 cycles. They're pretty aggressive in this, in that they did not cancel patients unless they had more than 4 follicles. They were aggressive. These were young patients, and gonadotropin doses were 150 international units, which kind of makes my heart flutter a little bit. I think that's pretty aggressive. And pregnancy cycles, or pregnancy rates per cycle for Clomid, 9%, letrozole 7% with IUI, cumulative live births, not statistically significantly different. And the multiple pregnancy rate for Clomid was 9% and 13% for letrozole. Again, they're all being used to superovulate, so therein comes the risk of multiple pregnancy. So the summary from it differs a bit from the Canadian. The American outcome is that really in the States, letrozole is not FDA approved, but it's considered a reasonable option if it's well tolerated and someone does not want to use Clomid or perhaps its side effects. Whereas the Canadians say this is totally an appropriate option for unexplained infertility, either oral agent with IUI. It's better than expectant management, and both are suitable. Now, gonadotropin superovulation with timed intercourse has never been looked at in an RCT compared to expectant management with unexplained infertility, so insufficient evidence to recommend it. But with IUI, lots of studies looking at it for superovulating, and a Cochrane review, and it definitely shows that pregnancy rates are higher versus expectant management, but obviously multiples are greater. And they quote multiple rates of 5 to 12%, which really aren't that shocking when you're considering superovulation. But when you see the Amigos trial, where again, more aggressive, more follicles being strived for with bigger doses of gonadotropins, you're going to see much greater live birth rates of like 32%. With Clomid, they live birth rates of 23%. But if you look at the multiple pregnancy rates with gonadotropins, 32% in 10 sets of triplets amongst these patients. There were 300 patients. And 9.4% with Clomid. Now, I put this image on the side. I have seen quintuplets from Clomid when I was in training, and we published this. Thankfully, all 5 delivered at 33 weeks and were very well. But this kind of outcome with Clomid is exceptionally rare. It's really not common. When you do a full data review, like a good trudge of all the papers out there, it's really, really uncommon. But if you looked at Amigos and you continue to compare it to letrozole IUI, it's still reasonable pregnancy rates with letrozole. But what you should take home from this is if you start with higher doses with gonadotropins, you're going to have live birth rates that are high, but also really high risks of multiples. And so the summary with this is you could offer gonadotropins in IUI, and that would be the Canadian look at things. The higher the doses, be careful because you're going to get greater risks. And ASRM says it's not recommended to use gonadotropins IUI due to the risk of multiples. So in unexplained infertility and their treatment algorithm from the States, they're like, just avoid gonadotropins altogether. And then the FASTER study from 2010 is a really great study because it looked at what should you do practically with patients who are under 40 unexplained, and what kind of process algorithm should they go through. And so they had a conventional protocol and an accelerated protocol. In the conventional, they got Clomid and IUI for 3 months. And if they weren't pregnant, they were offered gonadotropins and IUI for 3 months. And if not pregnant, went on to do IVF. And in the accelerated protocol, they just dropped the gonadotropin step and just went straight to IVF. And what they showed with that is there's a shorter time to pregnancy. You got pregnant quicker if you went on to just do IVF. Fewer treatment cycles, and there actually is a significant cost savings. Now, the cost saving part, I would say, is interesting because if you're a patient that's paying for treatment regardless out of your own pocket and you hear what the cost of IVF is versus gonadotropins and an IUI, you don't really care about the cost savings because you just maybe can't pay for IVF at all. And so those patients will really want to do gonadotropins IUI. Whereas if you're trying to come up with a strategy for funding IVF or funding fertility treatment in a country, you would want to avoid gonadotropin IUI for the additional cycles and the additional costs incurred that don't lead to live births. You actually save money for your population if you were just to go into IVF. And that's what they've shown from this study. And certainly where the UK's algorithm comes from. And so the NICE guidelines are built on this. They advise against use of gonadotropins, move directly to IVF. And again, IVF, an elective single embryo transfer as a strategy to eliminate multiples, is very effective. And we showed in Canada in our Quebec experience back in 2011, where Quebec as a province actually covered IVF for their population. And it was mandated elective single embryo transfer. They essentially eliminated multiples. I have to say it ended up being more expensive doing this because more people had access to fertility treatment. It ended up being more expensive. But the biggest barrier is going to be funding. So IVF, I've just put like a summary review, but assume that most of you at this postgraduate level would understand all the steps involved with IVF. And just thought I would give you the summary evidence that the current evidence does not support IVF as first-line over expectant management or a short course. And this comes from ASRM's guideline on the management of unexplained infertility. And this is when you're younger, when you're under the age of 38 years. Now, when you're older than 38 years, there certainly is very good evidence for immediate IVF and with a higher rate of pregnancy and a shorter time to pregnancy. And there is good evidence for immediate IVF after failed ovarian stimulation with IUI. So, I mean, that algorithm from the FAST study certainly seems to be very reasonable and has been built into these guidelines from Canada, the States, and the UK. So ICSI, so intracytoplasmic sperm injection at IVF is controversial. Many clinics do it routinely. The best evidence is that ICSI is required. So you're actively injecting a sperm into an egg when there's a male factor. For non-male factor, it's not thought to improve live birth rates. However, I'm asked this every day too, where I have a young couple who say, well, couldn't our infertility be failed fertilization? I'm like, yes, it could be. And they're like, well, I don't want to pay close to $20,000 for IVF with their medications and all of the stuff involved with that, and take a 5 to 10% risk of having nothing from that treatment cycle that you can't identify. So certainly I think ICSI is overused by patients because they want to avoid failed fertilization. They recognize that the live birth rate is not going to be improved, and you have to go through the potential risks of ICSI, which is a 1 to 2% increased risk of birth defects. There's a small RCT comparing standard IVF to ICSI that shows an improved live birth rate, but again, it's small, and that comes from 2006. And the Bader-Kyra group did another study comparing ICSI and IVF for non-male factor infertility that didn't show benefit in live births. But there is evidence for sure that you get higher FERT rates overall and lower total that should be failed fertilization rates. Rescue ICSI is difficult to perform if you're a really big lab with many patients in a day. It's hard to find time for rescue ICSI. So some clinics will opt to do ICSI upfront to avoid having to do rescue ICSI in an emergency setting where there's been failed FERT on a check. So the overall summary from the American side of things is couples undergo 3 to 4 cycles of ovarian stim with oral agents and intrauterine insemination. And if there's failure, IVF is recommended as a next step. The NICE guidelines don't offer ovarian stim at all in IUI for what the cost is. They say it's just not cost efficient. Try to conceive naturally for 2 years, and if you're not successful, they'll help you with IVF. And ICSI for failed fertilization only after a subsequent failed cycle of failed fertilization in the UK. In Canada, IVF can be offered as an effective first-line treatment. Certainly would be considered over the age of 38 as a first-line reasonable choice in the US as well. And IVF should be offered with unexplained infertility with the failed ovarian stim and IUI. And so I've put in my guidelines for you that I've used. A lot of them are being updated too, and I hope that was helpful and addressed all the pieces that you needed for today.
Thank you very much, Dr. Tallon, for an outstanding summary of a very extensive topic. I just want to start by correction. Actually, the article that you quoted, it's not me.
You?
It's not me. It's somebody else. However, actually, I was involved in a study that I did with Bob Casper in 2006 that was published in Human Reproduction. And that will probably address one of the questions posed by one of the audience about the use of a hybrid protocol, which is a combination of letrozole as well as gonadotropins with insemination compared to gonadotropins again alone. So in that study, we have shown that they have the same pregnancy rate, but less cancellation, less conversions to IVF, and it's more cost effective.
Yeah,
so
and in the guidelines, they're just like this, there is an added benefit to that. I felt like I was getting into a lot. There's so much evidence there. I was really trying to whittle down what we discussed. In the American Society of Reproductive Medicine, they do address it, and they say that they don't feel it's of added benefit.
Yeah. All right, Professor Tarek, it's your turn. You're muted.
Thank you very much, Dr. Tallon, for this very comprehensive talk about evaluation of female infertility and management of unexplained infertility. Now we'll start the question session. The first question, is there a lower limit of AMH or a higher limit of FSH to cancel fertility treatment in woman age 35?
So is there a limit to cancel treatment, meaning they're in treatment and you're doing it, or to allow access to treatment? Is that what we mean?
Don't allow access. For example,
Okay.
as you mentioned, the AMH is 0.01.
Yeah.
Would we...
So we don't limit access based on that, we counsel based on that. So we would say to the patient, you have a very low chance of responding. It's very unlikely that you're going to get an ovarian response. Now we'll do a natural follicle count. If there's follicles there, we'll say there's discrepancy between your assessments of ovarian reserve. And we'll just say your AMH is the most meaningful to dictate a low response. But if you want to try, you can try. Like you're full disclosure, transparent, but you're not using these tests to prevent them access to try. In someone who's 35, we would definitely offer mini stimulation IVF in our facility, where we would do an egg retrieval even for one follicle, given that she's relatively young, and give her the opportunity to see what happens. FSH, different story. I think if an FSH is really over 20, and it looks like they're menopausal, they're not cycling, their ovaries are quiet, I would just say, look, you need to do donor eggs. But for the most part, all of that is laid out up front in our counseling. And again, it's just to give them a sense of the realistic odds. Somewhere like the UK, where there's government funding, that patient is not going to have access to treatment, right, at all. So it will be based, and somewhere, in certain groups, like in Canada, in Ontario, we have coverage or funding for IVF. We don't here in British Columbia. Someone wants to try paying for it themselves here, they can. In Ontario, they would not be given access to IVF.
The next question is, what is the role of ovarian reserve testing in BRCA1 gene mutation?
Yeah, if that patient is going to do surgery, potentially look at having surgery, they may want to do fertility preservation, right? And so it may guide them in that. And also in someone, same thing, I see the question there, elaborate on the role of ovarian reserve testing in granulosa cell tumors. It's not that you're doing testing in granulosa cell tumors for ovarian reserve. It's that AMH is an ovarian reserve test, but is secreted in granulosa cell tumors. So you're using it over time.
Okay. The next question, is there a therapeutic role of hysterosalpingography in unexplained infertility? And if it is it the oil-based or the water-soluble based medium?
Yes, there's been a number of publications over the last few years on resurgence of this idea that HSG will actually bring an improvement in overall odds of pregnancy. And it has been shown in studies to do so, but again, with very specific contrast agents. We looked at trying to acquire that here in BC. One bag to do one procedure costs 1,000 Canadian dollars. So it's not something that is available, but it is specific. This improvement in overall odds of pregnancy for unexplained infertility is thought to be based on the contrast agent used and the oil-based primarily.
If you don't have it, we don't have it, or it's very expensive back home, so we use mainly the water-soluble.
Yes, that's the same as us. And that has not been shown to increase the chance of pregnancy.
But you still use it as first line investigation for the
tubes.
Getting the tubal patency test.
Correct.
Okay. The second question is, can you comment on the NICE guidelines which nearly omitted use of IUI?
Yes, it's based on cost, and they felt that it wasn't cost effective based on studies that Bedaiwy had done actually on looking at oral agents with IUI, and it was purely cost based.
Based, but not efficiency based.
No, my understanding. Yeah, I mean, the efficiency based is like a very marginal improvement overall, right? The best odds are about 9% with Clomid and IUI. And so with that, they just said no, for the given increases in live births, the cost was too great. And again, they fund treatment. So they push patients to try for longer before they get to IVF.
An important question. What do you think is the length of expectant management for unexplained infertility in the different scenarios? I.e. age-wise, a woman who is 25 and then is the 35 and 40.
Yeah, that's a great question because I think that's defined by patients. I don't think we define that. I'm pretty proactive. Like if you look at like total fertility rates around the world, we're under the replacement level because we're letting women, we're giving them too long before they're trying, right? If you look at pushing someone for too long who clearly has infertility and has a lower than 5% odds per month on their own, I feel that if they want to have a big family, the longer you leave them and the more you avert moving forward with definitive treatment, you're actually giving them age-related infertility later when they want to come back and have a second or a third child. So I feel that if they're defined in terms of we want 1 or 2 children, they're under 25, they have a good egg reserve, they look like the average 25-year-old, I totally think it's reasonable for them to take really up to the age of 34 if they really wanted to. But if you go past 2 years of attempts without really achieving a pregnancy, there's many places that argue and many studies to show this, you need IVF. Like really, you know, you're gonna gain way more from IVF. When you look at studies that look at the time to pregnancy with expectant management, if you compare expectant management versus taking an oral agent with IUI and you compare time to pregnancy, there's often no difference. You're just showing that those that are going to achieve a pregnancy on their own with more time may just get there with pills and an IUI, but the time ultimately can be the same. And those who never achieve either expectant management or with the easy treatment, they need IVF. So I wouldn't leave them too long. I failed IVF myself at the age of 38 from total age. I think like we underestimate the importance of a second or a third child for people. So I'm pretty aggressive in terms of like, let's just find out if you're going to find success with an oral agent and IUI. Are you ready to do that or not? And if they're not ready to do that and they want to take more time, I give them all the time in the world. If it doesn't matter what age they are, if they have low ovarian reserve, I'm going to tell them that they're putting their likelihood of success with IVF at greater risk if they're going to further defer attempts at pregnancy because they already have a red flag for poor prognosis. I see age as the following categories, like less than 35 as one, 35 to 38, 38 to 40. And then 41 and 42 as being very distinct age groups, just based on outcome from pre-implantation genetic testing. And patients find it really difficult and not tangible to understand what they're losing with time. But if you say to them, if your odds of having a genetically normal embryo from under the age of 35 is 60%, from 35 to 38, it's 50. From 38 to 40, it's 35%. That's tangible to them. They can see those age-related norms declining. And maybe they will achieve pregnancy on their own, who knows? But really, I don't see a lot of people, go past the 3-year mark that have a lot of success. They're usually coming back again and again.
Niamh, I just want to chime in here because I want to add to you another category, age category that's quite prevalent in the Middle East, which is under 25. I don't think you see that many of those. So maybe actually for patients who are extremely young and they have a lot of time, there could be more flexibility in trying non-IVF interventions, particularly where there are situations that they cannot afford the treatment, or the
Yeah, and
treatment is too aggressive for
again,
them.
because of the aneuploidy outcome in patients who are young, like in their earlier 20s too, I'd be hesitant to push them into treatment in their early 20s just on the basis of that too, you know, let them try more on their own in that really early 20 group.
Just to explain it a little bit, what Niamh mentioned is very important. There are two kind of peaks for aneuploidies, the too old and the too young. So there is a little bit of aneuploidy peak actually. We have shown that in a study that Ankar Kadakis did in their current pregnancy loss population, where between 20 and 25, we have a peak of aneuploidy in the products of conception of those patients who miscarried during that time. So long story short, I think what Niamh mentioned is applicable to people younger and older than 35, but not too young, not younger than maybe 25.
Okay. Actually, I was pleased that you mentioned diagnostic laparoscopy doesn't have a role in women with unexplained infertility. Can you explore more about this?
Yeah, that's in the absence of tubular peritoneal pathology, or in the absence of a history whereby they don't have pain, right? Your yield for identifying pathology or endometriosis will be about like much higher. The study showing like an 80% likelihood of finding endometriosis on laparoscopy in someone who has painful periods, right? So again, if they're young, they describe painful periods, or they have, you know, a history of STIs, surgery on their pelvis, other pathology that maybe led to surgery abdominally, an appendix that has ruptured in the past, and you're concerned about adhesions, certainly laparoscopy would make sense in that situation. But for pure unexplained infertility, where they do not have pain, you do an ultrasound, everything looks normal, they don't have endometriosis, their uterus is mobile on ultrasound, you don't see a fixed uterus with a question mark appearance suggesting adenomyosis and pelvic disease, you're very unlikely going to find anything that's going to improve the odds of pregnancy.
Because in some reports, they diagnostic laparoscopy as a criterion to define unexplained infertility. Without doing laparoscopy, they denied the nomenclature of unexplained infertility.
Mm-hmm. Yeah, it's interesting. I think that we've got to a point of what if you make a diagnosis of endometriosis that is minimal or mild? What difference does that make to their odds of pregnancy? And again, maybe if someone is 20 or 22, like very young, and you want to give them many years of trying, I would see value in doing a laparoscopy in that patient, just practically. But if you find minimal disease, I don't feel that by ablating or excising, you're necessarily improving their odds of a live birth. And that's pretty, like if you just look at numbers needed to treat, but what's the harm? We do many things, I think, because patients don't fit into these algorithms of exactly, you know, they don't move forward in the ways that we want them to, or they're not willing to, or they can't. There's barriers due to finances. And if they have a laparoscopy covered, why not? But I do think those references that say you don't have unexplained infertility in the absence of doing a laparoscopy, I think that's dated. I think it's dated evidence.
Okay. The next question is, what
was that? I missed that. I'm so sorry.
I can't see myself. Can you help me, please? Can you hear me, Dr. Tallon?
I can, yes.
Okay. The next question is, what do you think about the role of letrozole and gonadotropin in the treatment of unexplained infertility?
Yeah, I think Dr. Bedaiwy started out by asking that question. So there are studies looking at this, some suggest improvements, and I think the overall statement from ASRM is that there isn't added benefit given all of the studies that are there, and hence the potential risk of multiples, not to include that treatment strategy. I see there's quite a bit more evidence for letrozole and gonadotropins in patients with polycystic ovarian syndrome for ovulation induction that's resistant to letrozole or Clomid alone. But yeah, the ASRM guideline just said no added benefit. The Canadian guideline doesn't even address it at all. And the NICE guideline, they skip all gonadotropins and ovarian stim with oral agents. So it's not even part of that algorithm.
Yeah, even if you are going to use IUI with letrozole plus gonadotropins plus IUI.
Yes, they say no added massive benefit from doing gonadotropins in addition to letrozole for unexplained infertility.
Okay. The next question, if you still can hear me.
I can.
I'm not quite sure if you can see me. Anyway, what do you think, in your own opinion, would you take the opinion of 2 years and then IVF, or 2 years and then oral drugs and IUI?
Depends on age. If you're 40, go to IVF. If they give a patchy coital history where maybe you question that they're not actually getting together or doing things the right way, I would give them the opportunity of oral agents and IUI with the advice to move forward quickly. But I think if you're young, there is no harm in doing oral agents and IUI. Like if you've good egg reserve, you know, under 35 or even under 38, and you look like you've a good egg reserve and you're, you know, not looking for 5 children, well, then I think it's absolutely reasonable to go ahead with attempts at oral agents and IUI.
Okay, my last question is, how many cycles IUI would you recommend before embarking on doing IVF in women with unexplained infertility?
3 to 4 at most.
3 to 4.
Yes.
Yes. I'm sorry, the very, very last one. Would you consider shorter time of evaluation, i.e. from the beginning of marriage or beginning of relationship to infertility in women with social circumstances? For example, those who are serving in the army in our country, those who travel abroad to earn their money. So what do you think? Is there any need?
So interesting. What a great question. Yeah, I think that's a great question. I think that's a very practical approach. And I mean, I think I would talk to the couple about risks of deferred attempts of pregnancy, just, or, you know, given difficulty, you could look at freezing sperm in the absence of a male partner. If it's the female that's traveling or away, it's a difficult scenario. I think that is totally reasonable if they want a big family, or at least you try to help schedule things if they don't want a big family and they're relatively young, and give them information on age-related decline in fertility expectations and outcomes. But certainly fertility preservation would be something that a couple like that could look at, you know, doing treatment to freeze embryos for potential future use if they don't foresee that happening in the interim years. But that's really interesting. I feel like the patients that I see who get the worst outcome are those that are immigrants, who have had to move around the world a lot, whose lives have been disrupted because of terrible things, because fertility just becomes the least important of all of their endeavors. And I do think there's certain occupations, and certainly the military would fall into that put you at greater risk of just not being able to try. Great question.
Yes, because the connection is stopped. Unfortunately, here in Egypt, we can't use the cryopreserved semen or the cryopreserved embryos while the husband or the male is away. So yes, it might be easier to preserve fertility, but again, this will depend upon the date or when the husband or the male partner comes back. Can you hear me?
Yeah,
I can.
that's more of a social situation that's unique,
Yeah.
obviously, to the Middle East, Dr. Al-Hussieny. So that's why we don't really have that much experience with that here. But generally speaking, I think you have a wiggling room of 2 or 3 months, because the age of viability could be anywhere from 28 weeks, according to the Egyptian law, I guess, until term. So even after the husband travels, if the wife has cryopreserved sperm, or she has cryopreserved embryos, she can do 2 or 3 IUI cycles immediately after his travel, and then her expected date of delivery will be within the 28 weeks gestation that's suggested, so long as there is agreement between the clinic that's treating this couple and the husband and the wife. So if he travels after the cycle of IVF that she didn't get pregnant with, for instance, a fresh transfer, she can go for 1 or even 2 transfers following that immediately, and she will be still within the same frame as if her husband did not leave. I guess that's kind of more of a political solution here.
Okay, thank you. I think by this we come to an end to this very interesting webinar. Thank you, Dr. Tallon, very much. Thank you, Professor Bedaiwy, and I will leave you in peace. Take care of yourself.